going on in the world. That it's very much important to get accurate evidence-based information. So I wanted to start off with just talking with everybody about what I call the outline for cancer screenings, because really that's what this is about. Screening for cancer, identifying higher risk groups for cancers. I'm going to be focusing on mainly female-based cancers or female-presenting type of cancers, because my understanding is that the group in this organization is mainly a female group. But if you have questions about general cancer screenings, you can ask as well, okay? Because I do treat both men and women. And then also I'm going to separate that with the post-remission, post-cancer treatment section. So that way, if people have been through cancer or are going through a chronic cancer where they're living with cancer, there are discussions here about how you follow up with what we call your survivorship plan or your post-remission plan. And there are different terms that are used for it, but the point is that you have a support system, both emotional support, personal support, but also clinical support to get you where you need to be as far as functional. I tell my patients that it's not guaranteed longevity, but we can focus on improving quality of life and reducing morbidity and risk management so that people can have a greater sense of well-being. Okay. So the first thing I'm going to talk about is just standard cancer screening, starting with breast cancer, which is one of the most common cancers in women. This is the starting one that we normally use is at age 40. I know there's been discussion and different recommendations, but that's been somewhat of a questionable change. So we start with age 40 and we start screening women every 1 to 2 years. Definitely at age 50, they need to start being screened every 1 to 2 years. But from 40 to 49, women can have a discussion with their provider if they want to start getting a mammogram. For women who have dense breast tissue, they may need to have a breast ultrasound. I've had those myself, so I do understand kind of the difference between the two versus the mammogram versus the ultrasound. Also for women who have higher risk lesions, or they have a higher risk of family history or genetics that have been found in their family, they can get a breast MRI. Also, there is the clinical breast exam that's done with the provider, the physician or nurse practitioner, or physician's assistant. These are called physician extenders or mid-level providers as well as a doctor who do the breast exam. And there's a standard of training when I went through school of how to do a clinical breast exam. And research has been equivocal or not really consistent about whether it's better or less accurate for physicians to do that exam in the US. But in Canada, they found that a well-trained provider can detect lesions with a good clinical breast exam. So I do them and I encourage patients to have them done because it's, to me, part of a comprehensive well-woman exam. Also, you can do thermography, which is looking at the heat patterns of the breast tissue. That can sometimes be useful if you're looking at tumors that are deeper or more hidden, because a tumor will give off a lot more heat because they tend to be blood vessel generating, blood vessel producing and using, because to feed a cancer cell, it requires a lot of nutrients and blood vessels. Also tissue sampling, where they'll essentially just do a biopsy of a suspected lesion or cyst. That's another thing. That's for more higher risk results. And then the next one I'm going to is lung cancer screening. Now, lung cancer screening is something that's a newer phenomenon because for a while people didn't have any screening recommendations. They would just show up with symptoms like coughing, weight loss, coughing up of blood, coughing that wouldn't resolve, and then they get a chest x-ray, and if that was suspicious, and if they had a history, particularly of smoking or exposure to toxins, or people who worked in shipyards or in the aviation industry or race car drivers, they may have something of a risk with environmental exposure. But now the recommendation is a CT scan of the chest for somebody who has smoked more than 20 pack years. And a pack year means that you smoke 1 pack per day, and then that is considered a pack year. So for somebody who has that history, so let's say I smoke half a pack per day for 20 years, I have a 10 pack year history. That's the math of it. The point being is that the more you smoke, obviously, the longer you smoke, that combined gives you a greater tobacco or nicotine burden. And that's the carcinogens that can affect your lungs and can damage the actual tissue and put you at risk for cancer. Not just lung cancer, there are other cancers that are associated in general with smoking. but particularly lung cancer, because it's such a direct assault on the tissue. And so we recommend a CT scan every 1 year or every other year. And that is for patients age 50 to 80. That's the recommendation. After age 80, there's not as much benefit unless there's some other symptoms, but really it's a start from 50 to 80. And it's normally for patients who have stopped smoking in the last 10 to 15 years. Sometimes they may be a heavy smoker and they stopped smoking 2 or 3 years ago. I actually will screen them anyway, because you could be missing a tumor if you're waiting 10, 15 years for that person to be a non-smoker. So, and then after that, we're talking about cervical cancer screening. So cervical cancer screening is important because cervical cancer is a known cancer that can be lethal to women. We have cut down the rates of cervical cancer death and morbidity by doing pap smears. And that's something that we are very fortunate in the West here to have more frequently. We still don't have enough screening in some higher risk groups, women of color, women who are poor, even our younger women. It's harder to get them in, even the ones who are sexually active, I would say. And I do notice that with this pandemic, that has been a challenge to get people back into that regular screening and pattern of care. The recommendation currently is from age 21 to 29, you get a pap test and you follow up in 3 years if it's normal. If you have age 30 to 65, you only get a pap test, or you can get an HPV test, or you can get them done together. Now, a pap test will check for other abnormal cells. It will check for STDs or sexually transmitted disease infections, not HIV, but it will check for gonorrhea and chlamydia and trichomonas, which is important, especially if you are a woman of childbearing age, because it can complicate your fertility and put your pregnancy at risk. And then co-testing is where you check for HPV and the abnormal cells on the cervix. And that's important because HPV, even with a normal cervical cancer screening smear, can be associated with risk for tumor formation later on. Now, HPV, there are different types of the virus. It's not just one, but the high risk virus is what we test for with cervical cancer. So when you get that test, when you go to your doctor's office, that's what they're looking for, a high risk virus that is associated with cancer formation. And it can happen in men and women, especially for people who are HIV positive. They have an increased risk of getting complications from a high risk HPV infection. That's why we recommended the vaccine for HPV, which we now can give up to age 46 for both men and women. And the good thing about that is that it gets at preventing infection with the high risk HPV virus subtypes. That's key. Now, after that, we move on to ovarian cancer. This is a trickier one because there isn't a standard screening for ovarian cancer because it just hasn't been evidence-based and and tested thoroughly. Now, what we do recommend is an ultrasound of the pelvis and then a probe that goes inside the vagina to look at the ovaries and also the uterus. Also, if you are doing a monitoring test, if you're worried about that, you also can do what's called a CA-125. That's a blood test. Or you can do it to test when patients have unexplained signs and symptoms like weight gain in the lower belly, bloating, constipation, and disruption of menstrual cycle that is not explained. But also that should come with a full pelvic exam. And the pelvic exam is like the pap smear without doing the whole pap smear per se. So you check inside the pelvic cavity for the uterus, and also you feel on top and within the pelvic cavity for the ovaries. That's important. And you check to see if there's any pain, any fluid shift, and also if there are any masses. That's very important. And you should be talking to the patient as a provider. They should be asking you if you feel anything and explaining the process to you. Never do that exam silently. That's a very personal and intimate exam. It needs to be done with the consideration that there could be discomfort or trauma that the patient has experienced, and you don't want to do that without respecting that truth or that reality for many women. Now, there are increased risks for women to be screened for ovarian cancer. One, if there is a family history with a known clinical symptom. Two, if they have endometriosis, that's also a risk. Three, if they have a history of any kind of pelvic organ cancer. okay, or breast cancer. Also, people who have specific ancestry, such as Eastern European or Ashkenazi Jewish ancestry, there is a higher rate of certain types of ovarian cancer. Also, if they have never given birth, or if the patient has had trouble with their fertility, that is also associated with increased presence of ovarian cancer. And also genetic mutations, such as BRCA1, BRCA2, or Lynch syndrome. Any of those can increase your risk of pelvic organ cancers, particularly related to your ovaries. And for women who are over age 45, they also are at an increased risk for ovarian cancer, because cancer is something that happens more often as we age, because our DNA that is supposed to be monitored and screened and corrected over time can get damaged, and it can acquire little damage, little damage, little damage. And if we are not able to clear out that damage in our bodies, it can accumulate, and sometimes it doesn't cause any real damage to our system. But sometimes those DNA nicks and breaks can actually lead to abnormal cell growth, which leads to cancer. So that's why you see, as people hit 50 and up, you have an increased cancer risk in general compared to people who are under that age. That's why. Moving on to colon cancer screening, okay? There are 5 types of screening that you can use for colon cancer, all right? And maybe you've had different ones. I know depending on where you get your healthcare, that can be something that is a bit confusing for people. So I wanted to break it down into something more simple. 5 types that I would go over would be fecal occult blood testing. They're looking to see abnormal blood in your stool. Another type of sigmoidoscopy, they take a little camera and look in just the short end of your colon, called the sigmoid colon. That's the end of the colon when you have a bowel movement where you expel your stool. That's what they're looking into to see if you have any polyps, hemorrhoids, ulcers, lesions, anything like that. They can also do a biopsy too. And this is for people who have intermediate risk, or maybe they've had some symptoms, or they had an abnormal test, or they're expressing very specific clinical history that relates to possible sigmoid colon disease or disorder, okay? Also, there is a colonoscopy. That is the full camera exam where they do the whole lower GI tract, where they go literally from the right side all the way across to the transverse down to the left side of the colon. And that looks at everything. And they can take biopsies. They can look at the wall of the colon to see if there's any damage. It's also good if you have other types of colonic disease like Crohn's disease or ulcerative colitis or microscopic colitis, things that are chronic and can actually put you at increased risk for colon cancer because they're chronically inflaming the lining, but it's not cancer. All of that needs to be looked at. So a colonoscopy is good for that reason. Also, if you have a family history of early onset colon cancer in like a primary or second degree relative, they also will take that to use for early onset screening for people. So that's important to know. And if you want to know who needs to be screened, we're going to go over that right now. Screening is recommended now for age 45 to 75. We are seeing an earlier onset of colon cancer in patients who did not have known risk factors, who were healthy, were non-smokers, did not drink that often, and did not have a history of colonic disease or disorder, okay? Or family history per se. So we're now recommending a screening from age 45 to 75 as a standard. For African American patients, men and women, the recommendation now is age 40. Okay. And then screening should be for high-risk patients 10 years earlier than your youngest relative who had colon cancer. So if you had a relative who had colon cancer at age 45, you need to have, and this is a blood relative, okay? Blood relative, because that's the genetic concern that we're having. If you have a relative who had cancer at age 45, you need to get screened at age 35. And that's just the standard. And I've done that for patients as well when they've had that history. Now, another thing that we need to look at for indications in general for early onset cancer screening, just in general. Okay, so I'm going through this list that I kept here because I wanted to give you guys some more information for high risk situations. One, a personal history of cancer that always puts you at risk for other cancers. And I've had patients who had childhood cancer who developed sometimes 1, 2, or 3 types of cancers within their lifetime by the time they were in their 30s because they had been exposed to treatments like radiation, and then maybe got some cancer fallout from that complication. So it's important to keep monitoring. And if they have a genetic mutation in their history, that also puts them at risk for future cancer. So they need to be monitored and screened lifelong, really, if you have a childhood cancer. It's very important. Two, if you have a family history of cancer, and again, I stress with a blood relative, first or second degree. First degree means like your siblings or your parents. Second degree is like a cousin, an aunt, an uncle, or a grandparent. That is the next layer. And that can be considered, and I would say first cousin, just to be clear. And not a great aunt, more like your aunt from a sibling of your parents. And then your primary grandparent, not your great grandparent. It's still important to know that history as well, going back further into the generations, but what's genetically and clinically relevant is more the first and second degree, because that is closer to you, both in time and also in genetics. And then also, if you have known gene mutations, either in yourself or in your family history, that's important to be screened earlier. If you have exposure to known carcinogens, so this includes asbestos, with people who worked in the race car industry, who worked in shipyards, who worked in aviation. This is also aniline dyes. People can get bladder cancer associated with that. Exposure to certain types of dyes and toxins can also be associated with certain blood tumors and blood cancers. So again, all of this is very relevant because there are environmental documented correlations. There's even a type of vaginal cancer that is associated with DES. It's called diethylstilbestrol, and it was used as a topical pseudoestrogen in the 40s and 50s to prevent women from having miscarriages. What they found was that the granddaughters of these women were actually at increased risk for vaginal cancer, not even just their daughters, granddaughters, because of the way the effect of that medication was, because it was a pseudoestrogen, so it worked in the body on the DNA. So that's important to note. And then also, if you had unexplained blood clots, if you're somebody who's getting blood clots and we don't know why, and you're on the right treatment and you keep getting them, that's worth an investigation to see if what the issue is an undiagnosed cancer. And often you can have cancers in the gut that no one notices for a while, and then you may have a blood clot, and all of a sudden you do a scan and you find tumor growth. So that's another way to pay attention and kind of clue in that there's something wrong. Also, being older, again, growing old is a privilege. It really is, because you can acquire genetic risk and damage over time when your body is less able to repair itself. So getting older can put you at risk for certain types of cancers. And so that's why we start screening with cancer screenings, usually over age 50, or now in certain cases over age 40. Also, unexplained anemia or blood loss. If you have someone who is anemic, which means their blood cell counts are low and their iron levels are low and you can't figure out why, or they're losing blood for some reason and you can't identify it, that's a reason to investigate if there is a cancer issue. Okay. And then also, if you have a spike in what's called your white blood cell count. The white blood cells are part of the blood count, the complete blood count. They are a type of blood cell that is essentially used for protecting and defending the body from infection. And they're part of the immune system. I'm sure you've heard a lot about that with COVID and everything like that. But in particular, our white blood cells called lymphocytes are known to be the ones more vulnerable to getting a cancer type of presentation. They're not the only ones, but that group is where we often can see blood tumors develop, but they're not exclusive to just those types of blood cells. But it's important that when you start seeing that, you have to start looking, what is the cause if there's no infection for the white blood cells to be so elevated? Okay. And then follow-up is the next step. So if you have survived cancer and you are in what they call remission, which means 5 years of undetectable disease, the next plan is what to do. And there are different terms for it. What I looked at, they called it survivorship care, and having a survivorship plan. And you can actually go online and get the handouts where they go through what is your survivorship plan as far as designated follow-up screenings, your primary care provider, your specialist, who is your emergency contact, your resources in the community, your resources that you have at home, all of that to sort of itemize how to manage your recovery. And if your recovery changes, if your life changes, what can you do to arrange that plan differently to support you? And this includes having something like a good primary care provider, and that can be a physician, a nurse practitioner, or a physician's assistant, an oncologist that is a cancer doctor, specifically that's a physician who's trained in cancer care, certified. Subspecialty care, that can also mean a lung doctor, a heart doctor, a kidney doctor, depends on what other problems that you have where you may need other treatment and monitoring. Surgeons might be necessary. Those are doctors who are specifically trained in surgical correction of cancer and disease. And so they may need to follow you because you've had surgery and there are complications that they need to monitor. Or maybe you had a transplant and they need to monitor you after you've had the transplant. And then your treatment summary, which means all the things that went into your treatment, and then what are the concerns or follow-up from the specific treatment that you got that need to be observed, long-term and short-term. Also going over the side effects of your treatment, understanding what kind of symptoms you may have. There are certain drugs that give you a risk of heart failure. There are certain drugs that can scar your lungs. There are certain drugs that can cause you to have numbness and tingling in the legs, or what we call neuropathy. All those things, along with the hair loss, which is often the most well-known symptom of chemotherapy drugs, but all of that is part of the side effects. And then also living with chronic cancer. Some cancers are incurable or not surgically amenable, which means you can't remove them with surgery. So they become cancers that you live with long-term. And that's not uncommon now. We're seeing that complicated cancer after a treatment, especially when people have recurrence after they were in remission, it may be that they just live with it because they're at an age and stage in their life they don't want to have to go through experimental treatments or chemotherapy again for a marginal benefit. So it's really important that you consider that, because some patients don't want all the chemo. They just want to have quality of life and spend the time that they have doing the things that they enjoy. And then also how to do rehabilitation. You maybe had some injury because of your cancer, or you've had a change because you had surgery, like with breast cancer, and you have to learn how to repair the tissue that's been damaged, recover from the pain that you had, recover the strength that you've lost. We call that functional status, what is or performance status. How is someone's performance status before, during, and after cancer treatment? And how we restore the performance status to something that is more tolerable and something that's more acceptable to the patient. They can live a more independent life. You're trying to get to as close to independence as you can and without risk to the patient. And there are some cancer survivorship resources that I came across, and I'm going to email those to Rachel and to Allison, so you can have that later on. So give me a day, I can put it together, because there's actually quite a bit out there that's really great. But that's it. This is my presentation. I know it was kind of brief, but I wanted to cover the things that I thought were high yield. There are a lot of other cancers, but the screening is not standardized for most of those that are not on this list. And again, this was more of a female-focused cancer prevention, because that was who was in the audience primarily. But again, there's other things for men when it comes to prostate cancer or testicular cancer. I do have patients that I see, both male and female, so it's not exclusively to women. I'm not a gynecologist. Internal medicine is for adult men and women. Okay, so that's it. Thank you for your time, and I'm happy to take questions for the next, I guess, 20 minutes or so.
Thank you so much, Dr. Keke. That was so informative. And I think just all of these screening tools that you shared is really a proactive way to take charge of our health. So really appreciate that information. I did get a couple of questions through the chat, and so I want to invite people to continue to send their questions through the chat, or you can unmute yourself and ask questions. First and foremost, this is kind of just a quick answer one, but somebody just wanted confirmation of the blood test that is used to screen for ovarian cancer.
It's CA-125, and normally it's done for monitoring. Like if you have, like, let's say some symptoms that are concerning, like weird vaginal bleeding, disrupted menstrual cycle, weight gain, bloating, and let's say they find a lesion on your ovaries from imaging, and there's something that they find on a pelvic exam, and you have a family history, or maybe you don't. That's not always guaranteed. What they can do is do that CA-125 test and check to see if it's elevated, because that isn't normally an elevated protein marker, but with somebody who has ovarian cancer, it might be. So the absence of that does not mean you don't have it. I just want to say that. So absence of evidence, as we say, doesn't mean evidence of absence. So you want to look at other things, not just that blood test. You don't want to be consumed with the blood test and then you stop thinking and doing other diagnostic things or exam. Always examine the patient and check and keep looking at other things.
Thank you. Another question that I got was just if you have any information about other genetic markers to be aware of that elevate cancer risk. You mentioned the BRCA gene. I'm just wondering
Well,
if
there's Lynch syndrome, there's Lee-Fraumeni syndrome, there is Bloom syndrome and Wermer's. Also, if you have, I'm thinking of trisomy 21 is actually an increased risk for not just Alzheimer's, but also an increased risk for different types of thyroid cancer and also lymphoma. So there's that too. So anybody who has genetic inherent defect, that like a syndrome, for example, due to a genetic defect, you have to start looking at they may be at risk. And it's one thing when it's a young child, but when people survive to adulthood, we are seeing now because of the survivorship of those genetic conditions and mutations that more people are surviving. We're now having to be aware that that brings with it an increased risk for cancer, because the body inherently is impaired with certain reparative, on a cellular level, reparative functions. And that leaves you prone to multiplicity and amplification of damaged DNA that leads to cancer risk, if that makes sense.
Yeah, thank you. Someone just wanted clarification around the colon cancer screenings. Thought that they heard you list 5, but then only caught 3. So if we could just get a quick summary again of those.
Yeah, that's fine, because I know sometimes the feedback might not be so clear. So going back to the colon cancer screen, there are 5 types here. Okay. Fecal occult blood test, also called FIT test. So you get like what's called a FIT kit. You're testing for blood in the stool. Sigmoidoscopy, that's looking at the very end of the colon with a little camera. There's colonoscopy, that is the full colon exam with a camera that we used to recommend every 10 years. Okay. For people who do not have a high risk of colon cancer. You can also look at it when you have people who have increased risk of colon cancer, look at it at a younger age. And then also there's virtual colonoscopy. That is the one where you have a camera that's just live filming on the outside. It's not inside the colon, okay? And then there is a DNA stool test where you test for different types of DNA in the stool. And that's very specific because that is not just inflammation, that's looking for actual abnormal cell formation in the stool. So they were right. I think I missed one. So that's a good catch, because I actually had 5 here listed, but I may have not explained all that well. So thank you.
Thank you. Can you could go ahead and unmute yourself and ask your question?
Yes. My question is that regarding the breast cancer screening.
Mhm.
So when you're in that survivorship segment of your time, it seems that now what I'm hearing from the oncologist is that they no longer do. I had a bilateral mastectomy, and so therefore they no longer do any CT scans or MRIs to check on you. And instead, they will only do those if you have some symptom, pain somewhere or something. And I'm just trying to understand why it seemed to be that we used to do scans. That was seen as standard of care to do an annual scan at least after you've had cancer, and they're no longer doing them. And so I just wanted to understand the reasoning behind that.
I don't know exactly why. Some of the breast cancer changes, there's not full agreement on them. Like when the change went to age 50, I wasn't a fan of that change because we had so many high-risk women who already weren't getting screened. And then they made all these exceptions and said, if you're a woman with a cancer history, you have a family history, you have this ancestry, you're this ethnicity, you should. And I'm like, there's so many exceptions, just go back to age 40. It was just weird. And then the follow-up scanning also changed too. So I don't know. This might be because of the recent changes. Some of this was due to concern about overexposure to radiation. That was why the mammograms were initially changed to age 50, which, considering all the x-rays people get, I thought was a little bit strange. because you could get like 10 x-rays in 1 year and have one mammogram 1 year, once a year, or every other year, and it wouldn't be as much, you know. And also there was this other thought that maybe it was cost effective to have women start getting mammograms at a later age because it's more expensive to get a mammogram, obviously. But cancer is more expensive than having a mammogram. So to me, I think sometimes the priorities were a bit at cross purposes. And I can't speak to why that change has been made because that's a little bit beyond what I do because I don't monitor patients in that way, so I'm not an oncologist. So I would say to follow up with your oncologist and have them tell you why. I tell my patients why when those things change, and if I have an issue with it, I tell them why I have an issue with it. And I tell them what I'm going to do and give them the option to make their own choice. But I try to explain within what's under my authority. I try to explain it to the patient and then explain if I have a disagreement with it, why, and then give them the option to make a decision.
Well, I did speak to my oncologist and they said that basically that they had shown that doing the annual screenings did not increase your life expectancy.
Okay. Okay. So I don't think it's about life expectancy as much as identifying recurrence, because life expectancy would be that they caught the cancer and treated it successfully without major harm to the patient. So if the idea is that they're not catching a lot of tumors with that, that's one thing. But a screening tool is not treatment. It's a diagnosis tool. So if they're saying that it's not increasing life expectancy, well, it's not treatment. So the question is, that's not a complete answer, really. So I
Well,
would
that's
just,
how that's how I felt. I felt like some of it seemed to be more related to what the insurance companies were dictating as well. Like if it's not increasing, this, then it's not showing the benefit and
because,
on the
it's
other,
expensive. And it's
right.
expensive. So again, the question is, maybe they didn't feel that the life expectancy from the cancers identified warranted them paying for that amount. I don't know. This starts to get really kind of shady because this is some of the stuff that we don't even know about, all the behind the scenes, changes that are made, and I say that as a physician where I have to somehow explain to my patients why medication became $200 when it was $50 last week, So there is a lot of that. I would just ask your oncologist and say, when you say life expectancy, are you saying that this is a treatment tool or it's a diagnosis tool? Because that's a different thing. And I would ask and go further. I can't speak to it any further because again, I'm not an oncologist. But if you're dissatisfied, you can always get a second opinion. That's another thing too.
Well,
So
it is interesting because they did say, we would be more than willing to order the scan and have you get one. So they weren't adverse to having the scans, or giving the scans, but they just warned me that just so you know, the insurance company probably will not approve it.
yeah.
And then
or they'll expect you to pay for it. You might be able to
right,
get
right. Yeah, exactly.
Yeah.
Yep. Yeah.
I
Okay.
know. It's even when I got my own mammogram, it wasn't covered entirely by the insurance company, even though my doctor had approved it and I was of age, I was over 40.
Right.
I still had to pay a portion of it,
Mhm.
It's and it was standard of care. It wasn't experimental or anything.
Yeah.
And as a physician, I can say that. So I do understand personally, this is an ongoing challenge, I'll put it that way.
Okay, thank you.
Mhm.
We have just a couple minutes left. Are there any remaining questions? Okay. Well, I want to thank you so much, Dr. Akeke. I mean, it was such accessible, informative jewels that you gave us, and just really appreciate all of the attention that you provided to these individual questions and providing such valuable insight. We really appreciate having you here. So we'll give you a virtual round of applause. And we will bid you adieu. I am going to launch our workshop review. So for those of you who can stick around for one extra minute and complete that, that would be great. Thank you so much, Dr. Akeke.
Thank you to everyone. Good luck. Stay well. Please stay safe. Stay off Twitter. That's stressful. Okay.
Oh boy. Thank you, Dr. Akeke.
Take care. Bye-bye.
Thank you.
Bye-bye.